You want to get a real handle on what's new and important in healthcare, right? Something that could genuinely change how we receive care. Well, today, we're diving deep into hospital at home, this really interesting model where you can get, well, acute-level medical treatment without leaving your house.
It's a fascinating concept.
We've got a fantastic panel discussion to unpack, and we're really zeroing in on the crucial aspects of how it's funded and the policies that are making it happen.
Or sometimes making it tough, as you said.
Exactly.
And what's immediately striking is the global scope here. We're drawing insights from experts in Singapore, the United States specifically, focusing on Massachusetts Medicaid's approach, and Australia.
3 very different systems.
Each place is tackling hospital at home with its own unique set of challenges and, well, solutions too.
Exactly. So our goal today is to get beyond just the surface level. We want to understand the kind of nuts and bolts of the funding and policy frameworks.
How they actually work in these different contexts.
Yeah. What are the key obstacles they've run into? And what are the most compelling arguments being made for why this model matters so much?
And leading the discussion we're analyzing is Lisa Tripp. Her background is really fascinating. She was deeply involved in shaping U.S. government policy during the COVID pandemic.
Which was such a catalyst for this whole thing, with the waivers.
Precisely. And now she brings that really informed perspective to her advocacy work with Medically Home.
Okay.
And here's a bit of unexpected trivia. She's a passionate scuba diver, apparently even explores underwater caves in Mexico.
Wow, talk about navigating complex environments. That feels strangely appropriate.
Doesn't it? And then joining Lisa is Ethan from Singapore's MOH Office for Healthcare Transformation.
Real. He's right in the thick of healthcare innovation there.
Very much so. And it's clear hospital at home is something he's really committed to. It's fascinating to hear that a meeting with early adopters in Singapore, folks like Dr. Ian Hu, Dr. B. Lee, Dr. Michelle Tan, that really ignited the movement there.
And that international community aspect, too.
Oh, absolutely. It's really taking off. He mentioned it went from just, 31 attendees at a conference in Barcelona 2 years ago to 72 this year. That's significant growth.
It really is.
Oh.
And his personal connection.
Well, apparently, having grown up away from home, he deeply understands the comfort and value of, a familiar environment, especially when you're not feeling your best. It resonates.
That makes a lot of sense.
Yeah.
Okay, who else?
We also have Chuck Poe joining from Massachusetts. He's a geriatrician and internist working with MassHealth. That's the state government payer.
So he's seeing the real-world impact.
On a large scale, yes. And interestingly, he was connected to the early funding of hospital-at-home research back in Boston, so he's seen it develop over time.
Long-term perspective.
Exactly.
Yeah.
And outside of work, he has a strong connection to Norway, loves soup dumplings.
Okay.
And has this rather ambitious goal to play the top 100 golf courses in the world. He's already ticked off 35.
Impressive. Okay. And rounding out the panel.
That's Michael Young from Australia. He's a rural doctor by trade, tons of experience in telehealth and community-based care from Queensland.
Right. So a different angle again.
Mm-hmm. He's even founded his own company in this space and serves on the board of the hospital and the Home Society of Australasia. So a key voice.
And his fun fact, I remember this one.
Yeah, it adds a bit of excitement. He lives in an area with Australia's 10 deadliest animals.
Suddenly a house call doesn't seem so bad, does it?
No, not at all. Okay, so let's dive into Singapore's experience first, hearing from Ethan.
Right.
He describes a really impressive evolution over the past, say, 3-4 years. They're projecting 5,000 to 7,500 hospital-at-home episodes happening annually.
That's a significant number. Really shows momentum.
It does. And what's really notable is the speed of adoption after the pandemic.
Right. It kicked things into high gear.
Exactly. Small initial programs quickly transition into a full regulatory and financing sandbox in April 2022.
Okay, explain sandbox in this context again.
It's basically a controlled environment, lets them test out new policies, new funding models for hospital at home without the full-scale implications right away.
Like a pilot, but more structured around policy.
Precisely. And it was originally planned to run until March 2024, but it actually transitioned into mainstream practice early in April 2024.
Wow, ahead of schedule. That suggests it went well.
It does. And that intentional design of the testing ground seems really crucial for making such rapid progress.
So it wasn't just about small trials then?
No, Ethan emphasizes that. The fundamental aim from the get-go was to seamlessly integrate hospital at home into their standard healthcare system.
Okay.
By proactively building in those regulatory and financing parameters within the sandbox, they could learn, adapt.
In a more controlled way.
Exactly.
Yeah.
Paving the way for smoother mainstream adoption later on.
And when they were talking to their policy colleagues, what were the big questions? What were they grappling with?
Well, the core considerations revolved around three key areas. First, capacity.
Right. Can this actually help us care for more people without building new hospitals?
That's the question. Second, clinical and cost effectiveness. How did it stack up against traditional hospital care? Outcomes versus cost.
Makes sense.
And third, and maybe most importantly, the patient perspective.
What's the experience actually like for them?
Yeah, their journey through care, the ultimate health outcomes. Were patients happy? Were they getting better?
It sounds like they were really thinking holistically about it.
They were. And what's particularly insightful is their focus on the money side, the financial alignment.
How so?
They deliberately designed the financing for hospital at home to mirror traditional inpatient care.
Parity.
Exactly. The thinking was to avoid creating a financial disincentive. You don't want providers or patients choosing against it just because the money doesn't work.
Right.
Ethan even mentioned requests from political leaders to ensure financing was comparable, maybe even better, than traditional hospital stays.
Interesting. And alongside that,
A push for demonstrating cost savings and actually sharing those savings with patients, too.
so it wasn't just about the government's role in funding then. What about insurance?
Good point. Ensuring that all insurance providers in Singapore recognized and covered hospital at-home services was another critical piece.
Got to make it viable for everyone.
Exactly. Make it a real option for anyone who could benefit.
And as they scaled up, what were some of the, practical hurdles, the logistics?
Oh, yeah. Ethan highlights those. Significant logistical and operational challenges. Supporting a decentralized care model requires really robust processes,
I can imagine.
efficient logistics, smart procurement strategies. And as the program grew, the need for automation and seamless data sharing across different parts of the system became more and more important just to manage the complexity.
Okay, that's a great overview of Singapore. Let's switch gears now, head over to the U.S. Chuck Poe kicks off his part with that classic Yogi Berra quote.
The future ain't what it used to be. Yeah.
It's a fitting sentiment for a field that's changing so fast, like hospital at home.
Absolutely. He then lays out the basics of the U.S. payer system, which is, essential context.
Right, Medicare versus Medicaid.
Exactly. He clarifies Medicare federal mainly for older adults, folks with disabilities covering around 70 million people.
Huge numbers.
And then Medicaid, the federal-state partnership for low-income individuals covering about 80 million. And there's overlap, too. About 15% are in both.
Okay, that's the big picture. But the focus here is Massachusetts Medicaid.
Right. MassHealth. A big player covering 2 million people in the state. That's over a quarter of the population.
Wow.
And they began covering hospital at home just over 4 years ago.
So relatively early in the U.S. context, post-waiver.
Yes. And Chuck gives a really helpful timeline. It started with that crucial Medicare waiver in November 2020.
Okay.
Then MassHealth coverage followed quickly, early 2021. Hospitals started enrolling. Those Medicare waivers got extended.
Right. The uncertainty around those extensions has been a big theme.
Definitely. Then there was that presentation at the Barcelona conference, March 2023, which actually led to a strategic partnership for more analysis.
Oh, interesting.
He also mentions new Medicare billing codes coming in, CMS evaluation ongoing, and a recent waiver extension. It really paints a picture of, a dynamic and evolving policy landscape.
It does. He mentioned their approach rested on 3 main pillars. What were those again?
Yeah, design, operations, and regulatory.
Okay.
Under design, the mantra was think big, start small, keep it simple. And a key element, payment parity. Paying for hospital at home at the same level as a traditional hospital stay.
Just like Singapore, aiming for parity.
Exactly. For operations, they focus on administratively simple billing codes, trying to reduce the hassle for hospitals.
Makes sense. And regulatory.
There, they initially leveraged a special projects designation. That let them implement it without needing new state laws right away, which can take ages.
Shortcut, kind
The
of.
pragmatic approach, yeah. That focus on simplicity seems to have really helped them get started.
It sounds like that Barcelona conference was a real turning point for them.
It seems like it. Chuck explains it spurred a more intense focus in 2 key areas. First, stakeholder engagement.
Talking to everyone involved.
Right. Actively working with hospitals, the state health agency, the hospital association, participating in conferences to share learnings, build support.
And the second area?
a more strategic evaluation of the program,
Ah.
specifically looking at the experiences and outcomes for disadvantaged populations served by Medicaid.
Why that specific focus?
Because there just wasn't much data there before. They really wanted to understand the impact on that group.
That's important work. So what kind of results have they seen in Massachusetts? Has it taken off?
The numbers are quite encouraging. A 300% increase in hospital-at-home use by Medicaid members.
Wow.
And the number of hospitals billing for these services has tripled. But
There's always a but.
Chuck points out it's still a relatively small slice of the pie, a small percentage of overall hospital admissions in the state.
Okay. And he also touched on challenges, right? What stood out there?
Several key hurdles. One was just competing priorities within hospitals. Hospital at home is often one initiative among many.
Resource constraints.
Exactly. Then the inherent logistical complexities of setting up and running these programs, the upfront capital needed, especially for smaller hospitals.
It can be a barrier.
Definitely. The state-by-state variation in rules adds complexity, too. And then concerns around potential caregiver burnout, the impact on nursing workforce.
Yeah, workforce is a huge piece.
And just general knowledge gaps about the model, plus that ongoing uncertainty around waiver extensions we mentioned.
So a fair few obstacles still.
For sure. But he did circle back to those initial design principles that helped them get traction.
Right, the simplicity aspect.
Absolutely. He re-emphasized the importance of simplicity, that payment parity decision, the clear billing codes, and minimizing new regulations early on. Those seem to have been really instrumental at the state level.
Okay, let's hop over to Australia now. Michael Young points out their experience goes way back.
Yeah, over 35 years. That's a long history with hospital at home.
So it's more established there.
Much more integrated, it seems. Michael notes that nearly all major public hospitals and most private hospitals across Australia offer some form of it.
And he mentioned an organization playing a key role.
Yes, the Hospital in the Home Society of Australasia, an important advocacy group promoting the model, working on quality and sustainability.
Can you break down the funding in Australia? It sounded quite different again.
It is. It's a multi-payer system. You've got the Commonwealth government funding Medicare. That's the community-based insurance covering primary care, specialists, things like that.
Yeah.
The Commonwealth also chips in about half the funding for acute hospital services. The state governments cover the other half.
So a federal-state split for hospitals.
Right. And within the public system, funding can be activity-based, using DRG codes, those diagnostic codes triggering a payment, like he mentioned around $3,000 for cellulitis.
Okay, DRGs.
Or some hospitals, especially rural ones, are block funded. They get a set amount, not per service.
Right, and then there's private insurance.
Yeah, about 28 different private health funds. They all negotiate their own contracts with hospitals, so you get varying levels of reimbursement for hospital at home.
That sounds incredibly complex to navigate.
It can be. Michael shared that anecdote about one private insurer initially offering only a quarter of the requested rate for hospital at home.
Ouch. That highlights the challenge.
Definitely. And he also pointed out inconsistencies even within the public system across different states. Victoria was an early adopter, full funding parity, but others like Queensland, Western Australia, New South Wales were slower to get there.
So advocacy becomes really critical in that kind of environment.
Absolutely crucial. Michael underscores the vital work of their society in pushing for appropriate, equitable funding, safeguarding quality, avoiding that race to the bottom where cost-cutting compromises care. He also mentioned the society recently published a clear definition of hospital in the home, aligning with the World Society's definition, which helps standardize things.
That's useful. There was also an interesting point about funding during crises.
Yes, an insightful anecdote from Michael Montalto. Services that get funded at parity during health crises, historically, they've never had that funding pulled back afterwards.
Interesting. So it suggests payers see the value once they experience it.
That's the implication. Once they see it working under pressure, they tend to keep supporting it.
And Michael made a strong argument about the value proposition, didn't he? Beyond just operational costs.
He really pushed the idea of better, not cheaper care. Yes, there might be operational savings, but he emphasized the huge capital expenditure savings.
Avoiding building new hospital wings or buildings.
Exactly. Avoiding building new beds, which he estimated cost upwards of $3 million per bed. That's a massive savings.
That's a powerful argument.
It is. He argued funding models need to be reproducible, sustainable, and that looking at how the U.S. and Singapore are validating and funding this can offer valuable lessons for Australia.
Okay, so pulling all this together, Some really clear themes emerge across these different countries, don't they?
Absolutely. The absolute necessity of robust data and evidence, that comes up again and again.
You're proving the value.
Ethan's data collection in the Singapore sandbox, Chuck's focus on Medicaid data, Michael highlighting cost savings in Australia. It's all about demonstrating value.
And that concept of funding parity keeps surfacing.
Both Singapore and Massachusetts consciously aimed for it, aligning payment with traditional inpatient care.
Sends a strong signal. This is real equivalent care.
Exactly.
We also see these common hurdles everywhere, regardless of the system. Implementation challenges, scaling up, getting buy-in from all the different stakeholders.
It's never simple, is it? And the focus always comes back to the patient.
Right. Michael's examples of the young mother, the lawyer, preferring care at home, that convenience, that comfort.
Which often translates into those really high patient satisfaction scores we hear about.
Chuck even brought up the triple aim framework: quality, patient experience, cost.
Right. And how hospital at home ideally positions us to hit all three. Higher quality, higher satisfaction, lower cost. That's the goal.
Of course, the broader political and economic pressures are always there in the background.
Definitely. That anecdote about the U.S. congressman and DRG cuts illustrates that. And the fundamental structure, government-funded like Australia, insurance-based like the U.S., or a hybrid like Singapore, really shapes these conversations.
And Lisa Tripp's final point about needing more research on post-acute savings.
That's a really important one. If hospital at home leads to fewer readmissions, less need for rehab later on.
That strengthens the financial case even further for payers.
Big time.
So wrapping up this deep dive, what's really clear is that while the goal is the same, effective, widespread hospital at home, the paths taken are pretty diverse.
Very diverse, heavily influenced by the existing healthcare infrastructure in each country, how funding works, how regulation works.
But despite those differences, the underlying principles seem consistent. You need solid data to prove the value. You need effective, consistent advocacy.
Absolutely.
And there's this growing recognition that hospital at home can address critical issues like hospital capacity while also aligning with what many patients actually prefer.
For me, the real aha moments were seeing Singapore's very deliberate, structured sandbox approach. That was smart.
Yeah, proactive policy design.
And Massachusetts' strategic focus on understanding the impact on underserved populations, filling that data gap.
Important.
And then Australia's long history, but also their emphasis on those capital expenditure savings, thinking beyond just the operational costs.
Right, the bigger picture.
Yeah.
So for you, the listener, think about this. We've explored these different models, the challenges, the successes in funding and policy.
What do you see as the single most critical factor for long-term sustainability, for widespread adoption globally?
Yeah. And thinking ahead, are there innovative funding or policy solutions out there that could maybe bridge the gaps between these different systems, help accelerate progress?
That's your next area to explore. Food for thought.